And we are live. Hello, everyone. This is Dr. Vivian Asamoah. Nice to have you guys on the Natural Gut Relief once again. We are usually here every Thursday evening with an amazing guest. And this evening, just like we always do, we've got a wonderful guest all the way from the tri-state area, right? DC, Virginia, Washington. I brought her all the way in. I'm kidding, guys. She lives over there. She's got a beautiful practice over there. She's a board certified allergist. Her name is Dr. Karen Kaufman. And boy, are we lucky to have her on the show tonight. Before I introduce her, I want to tell you guys a little bit about myself. For those who are new on our Back to Basics in our Natural Gut Relief group, you may not know me. You may see my pictures kind of posting here and there. My name is Dr. Vivian Asamoah. I'm an integrative gastroenterologist. What does this mean? I'm board certified in gastroenterology, and I'm also certified in kind of integrative precision medicine and holistic medicine. So I combine the best of both worlds. And my passion is to help people with chronic gut issues, those who have seen multiple GIs, had multiple scopes, multiple labs, still can't figure out what's going on, use root cause medicine and, of course, food as medicine to establish a really healthy relationship with food and just thrive, have optimal gut health and thrive. So on Natural Gut Relief, every Thursday on Back to Basics, we talk about something related to the gut, something that helps relieve the gut, and we're going to talk about allergies today. So Dr. Kaufman, really nice to have you on. Tell us a little bit about yourself, your amazing practice, and we can start with questions.
Thank you so much. This is such a treat to spend the afternoon with you. So thank you. My name is Karen Kaufman, and I am a double board certified allergist immunologist, and I'm also board certified in internal medicine. And I help children and adults in my practice who suffer from allergies and problems with recurrent infections to feel better on fewer medications and improve their quality of life. I have a little visitor with me right now, so
yeah, he wants to be part of the show.
Yeah, so I have a private practice called Kaufman Allergy, Asthma, and Immunology, and we're located in Vienna, Virginia, which is right outside of DC. We're in the Tysons area, and it's fantastic. We serve almost 5,000 patients in the greater DC area and beyond. We do have patients that come to see us from all over the place. So it's just a real joy to be able to impact the lives of people not only in the community where I live, but in the area around us.
That is phenomenal. That is a beautiful area. I know Vienna is really beautiful. Tell us a little bit about why you decided to go into. So you're certified in allergy immunology, right? So you're really an expert in all fields. This is usually a very I hated allergy immunology as a student. It was so complicated. I was like cell, what immuno. It was so complicated. So I really admire you guys because you're super smart. And today, when we talk about inflammation, it's connected to the immune system, inflammation, immune system. So this is really your focus. But tell us, why did you go into allergy and immunology in the first place?
It's actually a long story. It's a circuitous story, but the short version of it was that, while I was a trainee in general internal medicine, just like we learned gastroenterology, we learned all of the different fields of medicine. And, at the time where I had my first exposure to allergy and clinical immunology was really the first time that I experienced getting to see both adults and children in my practice to be able to kind of impact not only the quality of life, but to allow these patients to grow and to age with an improved quality of life in so many ways, because the allergies in the immune system impact literally every part of us. And so I just found it to be really fascinating and enjoyable, and allowed me to get to see both kids and adults without having to do a residency in pediatrics, which was awesome.
That's nice. Okay.
Yeah, and so it's a combined fellowship. So we saw both pediatric and adult patients through fellowship training.
Awesome.
But I love it, and I always say there's something in medicine for everybody, and for certain, this is for me.
Awesome. So you are seeing kids as early as what age usually?
We see kids in the infant period. I usually don't see newborns, but we see infants and toddlers and kids all the way up through high school, adolescents, teens. And then we see adults through all decades of adulthood, all the way up through, their 80s and very rarely 90s, but you know, it's all different things. And it's fun because it's different aspects of allergy and different aspects of immune system problems that affect people at different times in their lives. So it's really
Mm-hmm.
fun. It just, you know, every day is different, every patient is
Mm-hmm.
different. It keeps it really exciting to be able to
Wonderful.
solve these problems.
That's really wonderful. I think the similarity here too is that um, once someone starts seeing an allergist, it's a continued relationship, right? They're always going to check in. So you're actually following people throughout their life's journey and how they're handling allergies and other allergies that may come up, which is really, really exciting. You kind of
It is.
get to follow their life, you know?
Yeah, it shares a lot of similarity in that way with primary care, and that, you know, you
Yes.
develop these relationships, the patients keep coming back, and then, you know, and then the parent who brought their child to you said, you know what, I think I should come and see you, and also my spouse, and
Yes.
my sister has these problems, she's going to come too. So, you know, we get to see, you know, the extended families of
Yes.
many of our patients, and it's just really nice.
That's awesome. Actually, that dives me into one of the questions. We can dive into the questions right away because I was thinking, are allergic issues hereditary?
That's such a good question. So, you know, the answer is yes, but also like with an asterisk, right? So
Yes
people
and
who,
no.
right? So people who have allergies much more often will have a parent with allergy. So whether it's allergy or atopic dermatitis or asthma, or you know, even when we talk about, I know we're going to talk today a little bit about food allergy, but children with food allergy often have, you know, have a higher likelihood of having a sibling with food allergy. So there's definitely a genetic component to what we see with allergy across the board. But you know, we're not talking about single gene defects where it's like grandma has an allergy to cat and so does my dad and so do I.
Mm,
Now
mm,
that might happen, but it's not because of a direct, you know, genetic linkage. So part of it is also environment, and our
mhm.
environment plays such a role with, you know, how our genetics modify based on, you know, our exposures, our experiences, and all of that together plays a role in the development of allergy. Absolutely.
Got it. Got it. Got it. So there is definitely an increased risk, right? But it's not a single gene defect. So it's not going to be an automatic thing like that whole autosomal dominant and recessive. It's not that. It's just probably there's a higher risk that someone in the family will have allergy or atopic dermatitis or okay.
Correct.
Fantastic. That's really good to know. So the question that we were online before we started recording, and I guess some patients come in with exactly the same questions, right? As a gastroenterologist, I always hear this: do I think I have a food allergy? Dr.
Yes.
Asamoah, I am having diarrhea. I am bloated. I'm like, when did it start? They're like, it's all the time. And it started, 4 hours or 5 hours after I had breakfast at Denny's, who knows? And is it a food allergy? And I'm like, okay, it doesn't sound like it. But Dr. Kaufman, tell us from an expert standpoint, when should someone really suspect a food allergy?
That is such a loaded question. Okay, so here's the deal with food allergy and really just food problems as a whole, right? Because not all of the food problems are food allergies. So this is like the how do you tease it out?
Mm-hmm.
In the grand scheme of food problems, there's two major groups. The food problems that are mediated by our immune system and the food problems that are not mediated by our immune system. It's like two very easy, distinct, different groups. And so it's important to have a good understanding of what are the different problems that can happen, because depends on what the problem is, it may present differently. So when we talk about the immunologic stuff, which this is where food allergy falls, right? We've got our primary food allergy, which is often what we think about with kids in school, and peanut allergy and things like that. We're much more accustomed to food allergies now compared to, 15, 20 years ago. But, these are problems of immediate hypersensitivity, right? So, it's mediated by allergic antibodies, and upon exposure to an allergic trigger, we have symptoms that fall within the spectrum of a systemic response. We call that anaphylaxis. So when it comes to the gastrointestinal symptoms that we can see associated with primary food allergy, we're talking about swelling problems. So swelling inside of the mouth, swelling in the throat, swelling in the visceral portion of our gut, which could manifest with severe abdominal pain, cramping. It could be vomiting. It could be diarrhea. And usually the time course of this is going to be seconds to minutes to maybe an hour or slightly longer. And usually the trigger is fairly obvious. Patients come in and they say, Dr. Kaufman, I took that bite and that's where the problem started. So they have this assessment at the time that they're eating of something bad is happening to me now. So it's immediate hypersensitivity. So again, usually a relatively obvious trigger, but what we don't need to trace it back to is like, what did you have for dinner last night before you went to bed and had symptoms this morning? For the most part, that's not how primary food allergy manifests. Now, there's one little caveat to that, and that is very prevalent here in Virginia, which there is a problem where after being bit by a tick that's endemic here called the Lone Star tick, you can actually develop an allergy to a carbohydrate that's found within mammalian red meat. And so you can actually present with delayed anaphylaxis upwards of like 4 to 6 hours after the ingestion. And it's just because digestion has to start taking place before your immune system will see that carbohydrate to then become reactive. So that's the little caveat to that. But all of that is antibody-mediated primary food allergy.
Got you. Okay.
Yeah.
Let's dive into so many interesting things here, because I want to hear about the Lone Star tick and and what kind of testing you do for that. But for the most part, when patients come to you and suspect they have a food allergy, and you do your detailed history and realize that, hey, this is something you ate the day before, you're not presenting with signs and symptoms of anaphylaxis, what do you tell them? What's the next step from there?
Well, we still have to do a little teasing out, right? So it depends on what was ingested and it depends on the symptoms. But when I think about gastrointestinal symptoms in particular, because that's what you're going to see in your practice, I think about things like celiac disease, which is not an allergy, right? But it's an autoimmune problem where the ingestion of gluten-containing grains will drive the immune system to target part of what's happening in the proximal part of our small intestine, where we deal with absorption of nutrients. And so we can see increased GI transit and diarrhea in that regard. So if the clinical history fits, I think it's reasonable to take a look at, or at least to consider celiac disease. And then, if it's diarrhea, I would say otherwise, depending on the time course, we start thinking about some of the non-immunologic mechanisms of food-related problems, which these are things that we call food intolerances. And they're tricky because they are completely correlated with foods that we eat. And it may not be a single food, but it may be natural properties of that food and other foods similar, where with ingestion of these foods, we then have symptoms that correlate. It's just that the problems aren't mediated by what the immune system is doing. And so in order to diagnose a food intolerance, really the best way to do that is with tracking. And so my patients know that they need to keep a food and symptom diary. So I am pretty old school about food and symptom diaries. I like pen and paper. I like looking at a piece of paper in front of me. And I like looking at everything in tandem. So I want to see food and symptoms following the same timeline, just like I go over with my kids, like a number line, right? So this is like a timeline through the day, and we kind of just plot everything out. I usually have my patients track for no longer than 2 weeks, because I feel like anything that's longer than 2 weeks, like everybody quits if it's too long.
Right. It's hard to track.
Yeah, 2 weeks, the end is already in sight from the beginning. So I think that that's reasonable. And then we sit down together and go through it. So what's so hard is that there are so many tests that are out there in the world that are marketed to us through Instagram and on the shelf at Target and whatever, right? So there's all these things out there.
On the shelf at Target too?
Believe
Are
it or
you
not,
serious?
you
Wow.
can find this everywhere. And it's a slippery slope because a lot of these tests are not validated, and they look at other immunologic markers for foods that don't really have anything to do with the problem that these people are having. So, for example, many of these tests look at IgG antibodies for foods,
Mm-hmm.
which is, really misleading to a lot of individuals because we look at these tests and we're like, oh, we've got all these antibodies to all of these different foods. I
There
must have
could be 30 or 40 of them different foods that now you have
very
to.
easly.
Right.
100%. Yep.
Mm-hmm. Mm-hmm.
So then they take all these foods out of the diet, and now we're dealing with issues of micronutrient deficiencies and stuff like that. So, what I tell my patients is this, our immune system is primed to look at all of the things in our body to say, look, what is part of myself? Is what I'm encountering part of myself or not part of myself? And then if not, is it then dangerous or not dangerous? And that's how our immune system determines, how do I respond to things? Well, it's normal to make IgG antibodies to foods that we eat because they're not part of ourself, right? We're not
Mm-hmm.
snacking on our wrist or whatever, right? Like we're eating foods that aren't self. So it is normal to make IgG antibodies. Usually what we see, like the highest levels of IgG antibodies, are things that people have ingested, in closest proximity of time to when the test was done.
Right.
It
Right.
gets really confusing for people, and sometimes people spend a lot of money on these tests because inherently we just don't feel good and we want to find out what's wrong, right? Or we want to know what to do to fix it. And so people go to a lot of lengths to try and do that. And unfortunately, there are some tests that just make it really confusing. So, in my practice, if the symptoms are concerning or consistent with what we think might be allergy, right, as we talked about, then we do allergy testing, right? And
Mm-hmm.
whether that's skin prick testing, which we do in our office, whether that's specific IgE antibody testing, which we would do at the lab, those are really the types of tests that are going to help to tease out food allergy. But what's hard about it is that if you tested somebody, let's say you tested me to like 100 different foods, you might
Mm-hmm.
find that I make IgE to several foods that I eat and tolerate.
Mm-hmm.
And so, the guidance really is not to do these big panels of tests for food, but to use the clinical history to guide the evaluation. Yeah.
And I can understand why that's really challenging because it's very common that we test for just blood work, using the regular standard labs. And we find very minute amounts, right? It'll grade it like, at stage one, level one, or level two. And the patient's like, well, I eat shrimp all the time, and I have no issue with it, right? And so in that kind of scenario, what would you do? Would you just, and well, this is someone who may have had some kind of gut symptom or even a little bit of, swelling in the mouth. What would you typically do in that kind of scenario when you see very low levels and sort of mild to moderate possible food allergy symptoms,
Mhm.
immediate food allergy
Yeah,
symptoms,
it's tough. So,
IgE?
I mean, yeah, it really starts with the symptoms. So, like, is the patient having clinical symptoms that could be suggested by allergy? If the answer
Hmm.
is yes, then the guidance is avoidance.
Okay.
And, and then further evaluation, which is, I like to do serial testing. So I like to test and test again. And not immediately, but I like to test, especially, I see a lot of children. So as children grow and we try to see, are they growing out of their food allergies? We want to see a
Hmm.
reduction in that specific IgE. And when we start to see that, we offer a food challenge in our
Hmm.
office to
Hmm.
prove that somebody doesn't have a food allergy. But what's really tricky is that there are many foods that share cross reactivities with their allergenic proteins with pollen allergens. And this is so
Absolutely.
hard because here in Virginia, everything's about to turn yellow in another month when the oak pollen starts dangling on all of us. But
That's a great time for your practice. I'd
we,
be there because I got a lot of allergies,
you
so
know,
pollen
um,
allergies.
today happens to be Groundhog Day too, and I saw that our
Oh,
favorite groundhog predicted an early spring. So I
oh,
don't know if
great.
I'm happy or sad. I don't know, but we're about to get real busy. But
Oh,
anyhow,
yeah.
yeah. So pollen allergy is a really, really prevalent problem. And many fresh fruits and vegetables, nuts, seeds, and legumes that we consume share a lot of commonalities with the allergenic proteins that are found in pollen allergens. And so, when we, let's say we did testing and we find that there's IgE of whatever number to some food where there's cross reactivity, it may truly be indicative of this really is the primary problem is your pollen allergy.
Mhm.
And now we have to watch out for, will symptoms develop with some of these foods? And sometimes they do, and sometimes they don't, and it's inconsistent. And it might be some foods in the category, but not others. And so
Mhm.
that's a whole nother evaluation, but an important one to know about, because those cross reactivities, um, particularly to answer your question of when you're looking at these test values,
Mhm.
there's a lot of subtleties of what we'll see in antibody levels when there are cross reactivities present.
So keeping that in mind, does the person also have an environmental allergy, so to pollen, and could that be a cross reactivity? What are some of the top fruits or vegetables, and this may be region specific, right?
Yeah,
That you're noticing in terms of cross reactivity?
it is. Yeah. So it's actually allergen specific. And so allergens
Hmm.
also are regional, depends on what that local
Hmm.
botany is, where you
Hmm.
are. So, for example, one of the most common is the birch family of tree
Yeah.
pollen, which is like
Hmm.
oak and beech and birch and alder trees, very prevalent here in Northern Virginia. And we see, very common cross reactivity in up to 40% actually of people who have these pollen allergies with, foods like apple, peach, plum, cherry, apricot,
Absolutely.
pear, avocado,
Mhm.
carrots, even like almonds and walnuts and soy and peanut and things like that. So
Mm.
lots of
Oh,
overlap.
oh, wow. Okay. For
Yeah,
nuts as well. Okay.
that's a
Yeah.
big category. For those who have ragweed allergies, sometimes we're talking about the melons, we're talking about
Hmm.
banana. Yeah, there's a lot of variety. And interesting about shrimp, you brought up shrimp a few minutes ago. Shrimp actually, the allergenic protein that's in shrimp is a muscular protein that holds like their little crustacean bodies to their exoskeleton. And that happens to be the same allergenic protein that we find in dust mites. So
Absolutely.
sometimes we'll
Mhm.
see that,
Cross
and it's not even a
reactivity.
cross reactivity because it's literally the same
The
protein,
same
but we'll see,
thing. Oh, wow.
yeah, we'll
Okay. Yeah.
see that dust mite and crustacean relationship. So
Got
that's
it.
a
Got it.
interesting
Very
one.
interesting. This is a
Yeah.
complex field, very complicated field, nuances, right?
Yes, there
And
are.
so tell me, in the setting of, if you do identify someone who probably has a pollen food allergy syndrome, or what we also call, you explained, oral allergy
Yeah,
syndrome, they may present with the classic symptoms of sort of like swelling in the mouth, irritation on the tongue, in the right, maybe even
correct.
irritation in the throat. I do see this quite a bit.
Absolutely.
So avoidance, and then focusing on what would be the treatment recommended in that scenario?
Yeah, so I usually suggest, I would say over 90% of the folks who have this react to the food in the raw form, but can tolerate it cooked. So if you bite into an apple and your whole mouth starts itching and your throat's itching and swelling, right, we're going to say don't eat apples. But if you can
Mhm.
sit down and have a slice of apple pie, enjoy, right? So
Right.
if it's tolerated in the cooked form, we don't do a strict avoidance. I will say that individuals who are at higher risk of anaphylaxis, like we talk about with primary food allergy, are individuals who react to the food both in the raw and the cooked form, or if they have a personal history of anaphylaxis, those are higher risk, and those individuals should strictly avoid. So, for anyone who has symptoms like this, it's always best just to avoid completely until you have an evaluation by your doctor. That's just an important thing to mention. But as
Okay.
far as treatment goes, aside from avoidance, interestingly, we treat many of these patients with allergen immunotherapy, which is allergy shots, not
Mhm.
for the food, but to fix their pollen allergy.
Right.
A lot of
Right.
times these things get better. So it's pretty neat. Not always, but often it does. So
Excellent. Excellent.
it's nice
Okay.
to
All right. So yeah, focusing on that usually will help that cross
yeah,
reactivity.
yeah.
Okay. Great. I'm sure that everyone is listening intensely because there's a lot of great information here. Let's go back to the Lone Star tick.
Okay.
Tell us more about that in case anyone is heading to Virginia. Tell us about the season. Tell us about the tick bite and what this can lead into. This is great information.
Yeah, so Lone Star ticks are endemic in kind of this mid-Atlantic area, all the way into like the Shenandoah Mountains and into Tennessee. And this part of the country, we have the Lone Star tick. So this is something that was first in the literature probably around, I can't remember, maybe 2011, 2012, something like that. I was a fellow at the time, and we had reviewed a great article that was in the New England Journal of Medicine about an allergy that people had to a certain type of chemotherapeutic medication. And what was really unusual was that these individuals were having allergic reactions of anaphylaxis like after their first dose, which was really weird because they had never had it before. And typically with allergy, you need to become, exposed and to become reactive before you start having, before you start having reactions. You have to become sensitized before you become reactive, is what I was trying to say. And so as they were sort of starting to study this group of individuals, and they were looking at patients with this problem all in different parts of the country, and in this area of the country where I live, they were finding that patients were also having delayed anaphylaxis after eating red meat. And the part of the molecule of that type of chemotherapy was derived from a mouse. And so then they said, well, maybe it's this mammalian protein, but why doesn't everybody have it? And then as they were teasing through the population of individuals, it was discovered that it's because they had been bit by this tick. So I do see this in my practice. I don't see it all the time, but I do see it. And in fact, I have a patient that I saw not long ago who came to see me for repeated vomiting. And it was a gentleman who had seen a gastroenterologist and had seen a whole bunch of different doctors, and nobody could get to the bottom of why he would have these episodes of vomiting. He would wake up in the night and he would vomit, like extensive, massive vomiting that would go on for hours. And he had terrible.
And that was the only symptom, Dr. Kaufman, was just vomiting?
Vomiting and abdominal pain.
Okay.
And so he came to see me to say, like, we don't know what this is or what to do, but can you help us? I get a lot of patients who that's the story of one version or another. And so sure enough, I like to kind of, think out loud with my patients and say, okay, well, let's think about it together. I love to sit around and think. And so, we'll kind of tease out, well, what are all the things in my field that can manifest with vomiting? That's kind of how I did it. And so we ended up doing testing for this particular allergy to this carbohydrate. And sure enough, he's got it. And so since I saw him, he's been avoiding red meat and his symptoms are
he's fine. Wonderful. Yeah. So this is the alpha-gal test.
Yes, it is.
That you can get through regular labs, Quest, LabCorp, CPL. And how accurate is the testing? If your suspicion is high, it's pretty good, right?
Yeah.
So yeah. And this is a test covered through most insurances. So not something that's specialty or anything, easily covered. Yes. So that's wonderful. So this guy just came to the right doctor after going to many other physicians, a doctor who took the time to kind of think through it, walk through the symptoms, ordered a variety of tests, and boom, like magic.
I was honestly surprised. I kind of said to him, like, well, this probably isn't going to be it, but I'd hate to miss it, and
how exciting when you find something, right? That's so great. And that you can provide relief. And he must think you're just like superstar.
The follow-up visit was actually very easy. I was like, oh, like, great. So just don't
eat red meat. That's it.
Of course, we went over an emergency care plan and all that stuff, but yeah, I mean, there's just a lot of value to having that knowledge base to be able to say, look, excuse me, this is something we might want to think about.
That is awesome. So you only know what you know, you don't know what you don't know. So I'm glad that we're putting it out there so other people can think of this possible diagnosis. And let's see, we've covered a lot of things. We talked about food allergy versus intolerance. You want to grab something? Grab some water. We'll wait for you.
I'm okay.
You're okay? Okay. Yeah. We talked about food allergy versus intolerance. We talked about testing.
Yes.
Skin testing and blood testing. We also spoke about oral allergy syndrome. So the cross-reactivity with pollen and fruits and vegetables, especially when they're raw, basically when you're eating them raw. We've actually also talked about alpha-gal syndrome and the Lone Star tick in your part of the world and the diagnosis you made in a patient. This has been wonderful. As we always focus on food as medicine, and we talked about, sometimes the solution is just avoidance for some time until you check the labs as the child, may potentially grow out of it.
Sure.
Let's touch on that for a second. You know, my kid, Eli, has a peanut allergy. He says he also has a chickpea allergy. I'm not sure if
Uh-huh.
there's any connection there.
Yeah.
Also allergic to eggs. I have snuck eggs in here and there because with baked goods he's kind of okay, but I have snuck eggs in here and there, and he's been okay. But if I offer him scrambled eggs, he's mortified. He's like, Mom, are you trying to kill me? You know, I'm allergic. When do you start considering, you know, when do kids generally outgrow this? How often would you test as you know, our kids get older?
Yeah, that's a really good question. So, I generally like to follow kids really no sooner than annually for most kids with food allergy. Although I will say, if we're close to thinking that, maybe this child is really close to proving that they're growing out of it, I may test in 6 months. But, I usually like to make sure I'm testing in, somebody who we diagnose, in their toddler age group. I like to test them before they go to school. And then periodically as they
Mhm.
get older, because, many children will grow out of food allergy, and it just depends on what their allergen is, right? So peanut,
Mhm.
like Eli, probably 20% of children grow out of peanut allergy. But
Mhm.
egg, I would say maybe 2/3 will grow out of egg allergy. So
Wow. Okay. Yeah.
with egg and milk, we start when we think that children are growing out of those allergies, we start with those foods in the baked form, just like he's eating baked goods with egg.
Mhm.
And the reason is because the protein is what we call a conformational epitope. So the allergenic portion of that protein, when it's heated to a certain degree, kind of unravels. And so it
Mhm.
just doesn't fit neatly in these receptors any longer. So usually when we're talking about, foods going through the oven, now I'm not talking about like a quiche or like a noodle casserole with 18 eggs or something like that, but like, let's say it's a muffin or a piece of
Right.
something like that, that usually is where we will start. Children who we think are growing out of it, we'll do a food challenge in our office. So we offer those in
Mhm.
office, so that way that takes a lot of the stress away from parents of having to feed their child their food allergen at home. And then once we introduce something like baked egg or baked milk, I like for that to stay in the diet regularly for a period of time before we would move on to introducing lightly cooked egg or uncooked milk or whatever. So, I like to follow antibody levels. Allergists do this differently. There's many allergists that'll do serial skin testing. I usually skin test at the time of diagnosis, and then I like to skin
Mhm.
test again before I go to challenge.
Mhm.
Just 'cause I want as many data points as possible to say, my pretest probability of success during this food challenge is high. I'm conservative. I don't want to bring a lot of kids in my office to have anaphylaxis while they're eating their food allergen in my office. If we can help it. So yeah, so I like to have as many data points as possible, but I do follow specific IgE antibodies serially, and I watch for trends. Yeah.
Fantastic. Okay, so that's really good to know to help kids getting more exposure to other foods
Right.
and being able to enjoy more when they go to the cafeteria at school instead of being so restricted, right? That's
Yeah.
hard.
And
Yeah.
also, I will say in our older teens who are ready to, leave home and go away to school or to go on to their adult life, especially for many of them who've had problems with food allergies since they were little, it's really important in my practice that we take the time to really teach these pre-adults or whatever we call them, these very young,
Mm.
almost adult children, about their own food allergy and what to do and how to manage it, because all of a sudden they become adults. And if nobody's ever sat down with them specifically and said, this is what you need to do, they're often, maybe not as focused on what's happening when the discussion is happening with a parent. So
Absolutely.
yeah,
Yeah.
so
What you need to do and make sure you have your pen with you at every
yeah,
opportunity. Yes, absolutely. This
yeah.
has been such a wonderful conversation. I feel like I could spend another hour with you here, but we don't have that time. I
It's
do.
really great.
I do want to steal something from you. That all
Okay.
that knowledge you have, I want to steal something. So imagine you've got this 35-year-old. She came to your office. She has like kind of like IBS like symptoms, but anyway, nausea, bloated, diarrhea, back and forth. She's like, I have a food allergy. I have a food allergy. She did all this food sensitivity testing from Target. It was confusing. It was a mess. You did your food allergy testing, skin and blood, didn't find much. Okay. What would be your parting words with her? How would you reassure her? What would the next steps be as an expert in the field of allergy and immunology? What would you tell her?
Yeah, I would say, as far as further testing and evaluation, things that I would look at celiac disease in that case.
Mhm.
If the person hasn't been tested endoscopically by their gastroenterologist already,
Mhm.
right, then you can do some serum testing and things like that to think about it. I will say that sometimes symptoms like that can happen um, when histamine levels are very high. And reflux symptoms can be part of that too. And so, we think about other reasons why people may be releasing a lot of histamine from their cells. And that includes things like environmental allergy and autoimmunity, and
Mhm.
even people who get sick a lot. Sometimes this will happen as part of their immune response. So I like to brainstorm about all that stuff and make sure we've thought
Mhm.
that through. And then aside from, if those are indicated, doing some evaluations, kind of going down those avenues, I would say a food and symptom diary is going to be of greatest utility to be able to tease out, is it even related to food, right? Because
Right.
sometimes it isn't.
It's not. Yeah.
And,
Mhm.
and I see a lot of folks who have, withdrawn different foods from their diet. That's fine. If they feel better being off certain foods, it's funny, just talking about celiac disease. So years ago, I feel like when people maybe started becoming gluten-free because they thought it was
Mhm.
healthier or something. I don't
Mhm.
really know exactly what was going on back then, but there
She says,
were a
I
lot
don't
of
know what
doctors.
was going on.
Right. There were doctors who would say,
Everybody went gluten free.
everybody was
Everyone was just,
gluten-free.
we're all
Right.
gluten free. Yes.
So there was a lot of doctors that would do testing. They would say, look, you don't have celiac disease. You should eat gluten. And that's actually not the right answer, right? If you
Yeah.
identify foods that make you feel bad, don't eat them, right?
Don't go
Like,
back
it's
to it.
fine.
Yeah.
It's
Hmm.
fine to do that. Yeah. And so, anyways, I think that like looking at food and symptoms in correlation to one another, it helps us kind of tease out because, for example, as we talk about histamine, like I have a fairly large population of patients who are histamine intolerant. Well, it's not one food. Like they can say, not to get into the weeds about histamine and foods, but like they could say, look, I'm just never going to ever, ever, ever eat another tomato. Good
Right.
riddance.
Any high
Tomatoes.
histamine.
I will never
Mhm.
eat that again. Yet then they go on and have a meal that's high in other high histamine foods.
Histamines.
So
Yeah.
it's like, it's kind of the teaching when you start to look at these diaries, you start identifying these trends and recognizing, particularly in that regard, it's a volume problem, right? There's only
Hmm.
so much that we can tolerate. And especially if your cells are already releasing your own histamine for whatever other
Hmm.
reason, right? That gap of what you can tolerate becomes very small. And so it's a
Hmm.
volume problem. So anyhow, it's a lot of fun to work through this stuff with patients because ultimately, the end result of it is we're either, we're identifying things as we get closer to an answer. We're ruling
Hmm.
things out that maybe we don't need to worry about any longer.
Hmm.
And as we kind of tease it out, patients start feeling better. We can do good things.
Absolutely. Absolutely.
So
So,
yeah.
Dr. Kaufman, I will say not every allergist and immunologist is a Dr. Karen Kaufman, right? Because you go deep dive. I send a lot of patients out. They come back to me like, she said there was no allergy, that, and I'm like, okay, we're gonna have to tackle this. I love
Right.
the fact that you mentioned histamine intolerance and high histamine levels because that has also been shown to be an important mediator for our patients with IBS. We see a
Yes.
lot of mast cell activation in IBS. So, it's really a pleasure for our audience to be able to have this opportunity to talk to you. It's a blessing, truly, because this is how deep and how far a good allergist and immunologist should go. It doesn't just stop at just a test and, well, it didn't show it, so goodbye, have a nice day. The
Right.
question is always, what else? Let's get a little bit deeper. Let's get that history again. Let's make sure we're going all the way. And eventually, let's make sure you're feeling better. You're at least getting some relief. So it is wonderful to hear this. And truly, it's been a pleasure having you on today. It's been so much information. I took notes in my chicken scratch handwriting.
Oh,
I
that's
took so many notes, but it has been an absolute pleasure. And I'm sure that everyone is going to have questions and wonderful comments. But should anyone be kind of trying to connect with you, learn more about what you do, possibly even have family or even live in your area, where can they find you?
So my practice is Kaufman Allergy, Asthma, and Immunology, and we are located in Vienna, Virginia. Our practice website is kaufmanallergy.com, and I can also be found on Facebook and on Instagram at Facebook is Kaufman Allergy, and on Instagram, dr.kaufmanallergy.
Fantastic. And I will post all of this in the show notes because Dr. Kaufman has shared her bio with me. And so we need you back on here again because we need to talk about mast cell activation, MCAS.
Oh, yeah.
We have a lot of patients who will be very, very interested in that. I think that's a conversation just on its own. So please honor us with your time and presence. We'd love to have you on again. Everyone, thank you so much. This was a wonderful conversation, so enlightening. Thank you guys for sharing another evening with us, taking your time off to learn a little bit more about what we do in our specialties. Thank you for spending time on the Natural Gut Relief Facebook group. Have a wonderful evening, everyone. Bye-bye.
Bye.
Bye.